next we have Dr. Rakesh from Chitrakoot, a prolific surgeon. I'll say one of the fastest surgeon in India. And he always has some amazing cases to show, very complicated cases. Dr. Rakesh?
So can you pause the video? Just pause it. So actually this patient was actually fallen from the tree, and he has the subluxated cataract more than 6 clock hour. Please turn the video. So actually that traumatic subluxation is that slightly 6 clock hour, and vision was 2/60 and IP was 26, and so actually for the, I do the phacoemulsification. After making the port, I just initiate the rhexis with the help of the cystidome and then complete it with the atrata forceps. So I make a rhexis slightly off center from the subluxation, and then after that we do mild hydrodissection. But during the hydrodissection, actually the vitreous was collapsed continuously. And then so do the vitrectomy again and make a conjunctival incision and make some scleral pocket, and then make a 3 ports for the implanting the capsular hook to support the capsule. After putting the 4 hooks, and then do the hydrodissection again and rotate the nucleus very easy. So after that we do the phacoemulsification with the help of the stop and chop technique and emulsify it in the iris plane. But during the actually IA, the continuously we see the vitreous was coming out. So I just lose the bag. You can suddenly so the bag is shifted toward the nasal side. And then after that we reposited the vitreous and then do the vitrectomy again and put the visco in the bag and inflate the bag. So I try to actually put the Cioni ring in this case. Initially the ring will go into the angle and then suddenly slip in the vitreous cavity like that. So I just try to remove it again and put the visco in the bag and put the hooks in the capsular to support the bag, and then try to again put the in the bag, but it is slipped again. And then the bag is shifted toward the nasal side. So in the after the 2-3 times, actually I saw the rings is actually in the engaged behind the iris. So I try to put the another CTR to inflate the bag. So after that, putting the half of the second CTR, then bag is inflated and try to actually rotate the Cioni rings in the antechamber and with the help of the 2 Sinski hook. Finally, actually after the some actually I faced the some actually difficulty to actually rotate it because it is engaged behind the iris and the capsule and the few part in the vitreous cavity. So and then finally I just remove it, and then second CTR is rotated and inflate the bag. And now we are actually, the bag is inflated. Again I put the Cioni ring, and then, but picture abhi baki thi. So I just, for the suturing eyelet, the suture was broken actually. So, and then I remove the suture and then think how to actually suture it. So make a slightly, try to pass the needle from this eyelet, additional eyelet, and with the help of the 26 gauge needle, I just pass it, and finally I got it, the suture, and pass it through that behind the iris, and then both needle was actually passed through the tunnel, either previously made. And then suture it 1 mm away from each other. And then now the bag is properly inflated and put the aisle in the bag. And patient actually, patient was young. It is about that 18 or 20-year-old, and after suturing this tunnel and then repose the conjunctiva. Initially first posture was 6/18, and after 1 month, luckily vision was 6/6. So thank you.
So, Rakesh, why that Cioni CTR was again and again slipping? What is the reason for that?
Actually,
I really couldn't make out from?
No, actually when we put the Cioni ring,
Because your capsule size was also adequate.
Yes,
it was good. Everything was perfect.
it is actually sometimes when the rexis was slightly bigger in this side, subluxus side, so it is slipped again by this region and engaged behind the iris and some part in the vitreous cavity. So, and then bag is suddenly, vitreous was prolapsed and bag is suddenly shifted nasal side.
Yeah.
So I actually think about when you put this another CTR to inflate the bag again and then try it. So then I achieve it to put it in the bag. And second thing is that I think I did the few mistakes in this case. Like I actually make the incision near to the subluxation. So during the phacoemulsification, the continued hydration of the vitreous. So that the vitreous come out again and again. Second thing, we can do the triamcinolone injection to cut the vitreous again.
That's what I was telling you, that like it's always good to put triamcinolone so that you can see that whether you've done complete vitrectomy or not.
Yeah.
And then put dispersive OVD that side, block that area, and then you can start. Or maybe if you feel that vitreous will prolapse out, another thing is you can put early CTR also, so that you know in that area the bag will get expanded in that area, in sub-incisional area, and then vitreous won't come out.
Actually, initially we should be planned to first we put the CTR, simple CTR, then you can put the CT segment or Cioni ring. It's okay for me. But I did, nowadays we actually follow this rule. But initially this part actually had happened during the surgery. Actually the patient was young, so I tried to put the lens in this case.
Actually, very nice surgery, sir. So I do agree to your point that probably it's best to do less and less manipulation at the point where you have the dehiscence, because anyways, not even hydration, even movement of the lip is going to cause more vitreous to come out. The second thing is that though in your hands, I think you've managed it very, very well, but I think in most of the post-cataract surgery cases where you use a CTR, the most common complication when you're rotating it in a bag is, outside and into that sulcus area is basically a GTR. So you can always end up with a giant retinal tear over there, and that's very, very commonly seen. So most of the CTR rings that I've taken out with the GTR have been with a giant retinal tear or a damage to the aura at that site, especially in these kind of cases where it's been tried multiple times. So, but probably in your hand it looked very nice and I think very well managed case.
Actually, another thing in this case, actually after the 1 month, patient was 6'6", and another actually in the patient has come another one second month. The patient developed the CME actually in this case. So, but it is actually resolved automatically with the help of Nepafenec and other things.
So you use this was 90 proline, I guess?
Yeah, 90.
Suture, So you use 90 proline because issue is of degradation of suture over period of time.
Yes.
So in these younger eyes, so now I have shifted to flanging. I use 60 proline.
Yes, sir.
Even to I flange capsular tension segment.
Yes, sir.
So that's very
segment
easy.
Is slightly better if you put the CTR and then segment. It's better. I
so
think.
Either use Gore-Tex suture, which is like it has a longer life than 90 proline, or flange it. Arup sir?
Yeah. So I think Rakesh, good video as usual. There are a few comments I wanted to make. Is of course, before you start off, we need to stain the vitreous, find out where exactly is the vitreous. Second thing is past on anterior vitrectomy would have definitely helped our cause in this case. And third thing is, right at the beginning itself, we could have used about 3 capsular hooks.
Yes.
And CTR may not have been necessary, but it's up to the surgeon. But capsular hooks so that you get a safe phaco. And what are the OVD used? I hope it was viscoat that you had used, or
Dispersive. Not to use the viscoat.
Huh?
I use the dispersive.
Yeah, HPMC definitely is not good for this kind of situations because it repeatedly comes out. So it has to be viscoat, which definitely preserve the make your surgery easier.
Actually, sometimes the high molecular viscot actually go into the vitreous cavity. It can cause the high IOP sometimes in cases. So by this reason, I put the.
In that case, the HPS is the worst culprit.
Yeah.
If your OVD is giving us to high IOP, viscot gives us to less IOP rise than HPMC.
But till the patient is about 6 or 7 years, and it is the stable and very
Yeah,
good
yeah,
vision.
true.
It is. Yeah, thank
Thank
you.
you very much,
Thank
Dr. Rakesh, for sharing this wonderful